Next speaker, let me introduce. Next speaker is again. This is very well known. The exceptional endoscopist and educator and researcher, Dr. Saito, Professor Saito from National Cancer Center. He's director of the endoscopy division, and he has so many publications in diagnostic part on colorectal lesions, how to treat EMR to EST, and has interest in AI use of the diagnostic part as well. So we're excited to have you. Let me hear your version of EST.
Thank you very much. Thank you for your kind introduction, Professor Norio and Douglas Rex. It is very exciting for me to discuss about colorectal ESDs with world experts. So time is limited, so let's move on my presentation.
My name is Yutaka Saito from National Cancer Center, Tokyo, Japan. It is my great pleasure to be here, and thank you for Professor Rex and Professor Fukami for moderating these sessions. No COI for this presentation. First topic is en bloc resection necessary for LST granular type? In LST granular type, 16% SM invasion were multifocal and difficult to predict before endoscopic resection. This proved only after en bloc resection case series. Pit pattern shows highest diagnostic accuracy. However, it is important to know the limitation of pit pattern, especially for LST granular type. The sensitivity of pit pattern is just 50%, and this means the half of T1 LSTGs showing non-invasive pit pattern. This data shows SM invasion rate according to the tumor size and LST subtypes. As shown, when the tumor size is more than 4 cm, the invasion rate was nearly 20% even in LST granular type. Next topic is ESD necessary for colon? In LST granular type, there was no correlation in tumor location for submucosal invasion. Some report rectum is a risk factor for SM invasion, but this might result from selection bias, only including EMR cases. In such EMR series, rectal region easily enrolled for EMR despite of SM suspected, but surgery would be conducted to proximal colon SM suspected cancer. This is a newly analyzed data from our endoscopy reported data. As shown, there is no SM invasion rate difference between colon and rectum. Multivariate analysis also revealed that tumor location of rectum was not a risk factor for SM invasion. LSTG, nodular mixed type located in the cecum, JNet type 2A and type 4 pit. No endoscopic finding for cancer, but en bloc resection was applied for this lesion due to the large tumor size. SM invasion was diagnosed more than 1000 micron due to the destruction of muscularis mucosa. Retrospectively reviewed, this SM deep invasion was really difficult to predict before endoscopic resection. Next topic is piecemeal EMR curative for large LST granular type. This is our retrospective case series of EMR and ESD at NCCH. We have experienced 2 cases of invasive recurrence, which required surgical intervention after piecemeal EMR. At the timing of piecemeal EMR, the tumor was diagnosed as interim causal cancer. This is high-grade dysplasia in the West. The surveillance colonoscopy was conducted every 6 months as a routine practice. No recurrence at 6 months, 1 year, 2 years, until 4 years. However, invasive recurrence, some mucosal tumor-like elevation, was diagnosed at 5-year surveillance. Surgery was conducted. Invasive recurrence rate was less than 1% in total, but increased to 10%, focusing on large LSTs, more than 4 cm. This rate is similar to SM invasion rate in LSTGs, more than 4 cm. In Japan, pathologists diagnose intramucosal cancer based on the nuclear atypia and structure atypia, but Western pathologists diagnose it only when SM invasion is evident. From this particular case, we could say that Japanese-style diagnosis is better considering the potential of metastasis of the tumor. Similar invasive recurrence were reported from the West, from Dr. Amit Bhatt group. Malignant recurrence occurred in 6 cases out of 229 patients. The incidence was 2.6% after piecemeal EMR. They concluded, when expertise is available, en bloc resection, such as ESD, should be the goal. Final topic is how to perform proximal colon ESD safely and effectively. Now, I'd like to show one case, LSTNG, pseudo-Deplis type, located in the cecum bottom. The center of this LSTNG is slightly depressed. Magnified NBI revealed a irregular vessel pattern and irregular surface pattern, suggesting JNET type 2B, corresponding to high-grade carcinoma. The right side and left side in the center revealed a different surface pattern. There is a demarcated depressed margin, but pit pattern was almost 3S and 3L pit pattern. In the center depression, the pit pattern was 5R severe irregular, but the area was small. Therefore, final pit pattern diagnosis was type 5I, non-invasive pit pattern. EC classification was EC type 3A. According to Professor Kudo's classification. The glycerol and mucoap was injected to the oral side of this tumor. After injection, the marginal incision was performing using the jet B knife, bipolar needle knife. In this situation, the retroflex was impossible. Therefore, we are doing the ESD using the straightforward view. And after marginal incision, it's really important to start some causal dissection immediately. And to make the goal definitely makes ESD easier at the final point. Now we change the scope to the anal side of the lesion. We are injecting glycerol and mucoap again. And we are conducting the partial marginal incision of the anal side of this tumor using the same jet B knife. And similarly, we are conducting the submucosal dissection immediately after partial marginal incision. Because even using glycerol and mucoap, the SM elevation disappear quickly in the colorectal ESD. It's really important don't perform circumferential incision. Now, when we encounter the thick vessel, we precoagulate the vessel. using a very low wattage from right side and left side. And after pre-coagulation, we could start some causal dissection again without bleeding. Now hook the tissue using the ball tip of the B knife and then move the knife along the muscle layer. Now this vessel is already pre-coagulated, so we could cut without bleeding. But of course, we should move the knife slowly when encounter this kind of thick vessels. And we could see the muscle layer left side and underneath. So in this situation, it's important to apply the traction method. Now we are applying the SO clip for the resected specimen. Now we apply the first SO clip to the resected edge. And then we apply another clip and attach to the normal mucosa, the opposite side of the tumor. Now you could understand the very nice traction achieved. And we are using IT Knife Nano, specially designed for colorectal and esophageal ESD. The chip is smaller, so we could performing the safe ESD. Now using the shorter pasty hood, we could visualize the cutting line directly. Now we are using the IT Knife Nano for some causal dissection. Now we are dissecting lower third submucosal layer. Now we are starting the lateral marginal resection of the right side using the same IT Knife Nano. And inside out cutting is very safe in this situation. And now we again doing the left lateral side marginal resection using the same IT Knife Nano. At this timing, almost the submucosal dissection under the tumor is already done, and the final dissection is just the oral side of this tumor. And the deeper submucosal dissection was done at the beginning of the ESD, so the final dissection becomes easier like this. If the first submucosal dissection is shallow, the final dissection becomes a little bit challenging. So it is important to make the final goal definitely at the beginning of marginal resection of the distal end. Now the en bloc resection completed safely without any complications. After en bloc resection, the histology revealed a well to moderately differentiated adenocarcinoma, and the depth of invasion was intermucosal. Lymphovascular invasion was negative, and horizontal margin and vertical margin were negative. How about this LSTNG in ascending colon? But magnified NBI and pit pattern showed non-invasive pit pattern. Even in the center depression, type 5I, low grade was observed, and the area was very small. So final diagnosis was 5I, non-invasive pit pattern. This is the endoscopy image just before ESD. Do you still start ESD for this lesion? Finally, en bloc resection achieved without complication. A resected specimen. Histology revealed well-differentiated adenocarcinoma, and muscularis mucosa invasion was diagnosed as a depression, but curative resection was achieved. Even in Japanese multicenter study, the clinical outcome of ESD getting better and better in recent 10 years. This is the comparison between ACE study and our data. The perforation rate was a little bit higher in ours, but the emergency surgery rate was same. The rate of SM invasion was also higher in our study. The target lesion might be different between two groups. Some ESD cases would be treated by surgery in the West. Let's summarize my presentation. JNET type 2B without invasive pit pattern is an indication for en bloc resection. Not only rectum, but also colon LSTs need en bloc resection when the size is more than 3 cm and suspicious for intermucosal carcinoma. AI technology will support our IE diagnosis in the near future. Thank you very much for your kind attention.
Thank you very much. That was a fantastic talk. So now the question, I think probably we should limit to one or two. Doug, do you have one? If not, I'm going to go ahead.
Naka, can I just ask you quickly? You know, we don't have, for the most part, the high magnification scopes. We have the, for example, with Olympus, we have Xera 3, but it does not have a real high level of magnification. So there isn't very much use of the JNET classification. But do you think we can apply the JNET classification? Can we learn this with the scopes that we have available in the US? Will it work?
Oh, thank you very much. It's a really important question. And our colleague also examined the near focus system will be available for JNET. But our colleague study showed that near focus is acceptable for the evaluation of JNET. So please don't worry. If you could use the near focus system, you could use the JNET and you could evaluate the JNET classification.
Thank you.
Thank you. So in your series, the SM1 invasion is much higher than Dr. Volk's group. And do you think that's more of a selection bias, or you're taking on more challenging case that it's salvaging patient from surgery?
Yeah, so I think the both might be the reason. The one reason might be that after en bloc resection, the accurate histopathological analysis could be done. And another reason might be that also we are a little bit challenging for the more aggressive lesion. But of course, Michael by himself, he is doing the challenging cases. But in the ACE study, it's a multi-center in the all Australia group. So I think we are challenging a little bit more aggressive. But another important point is even using pit pattern or JNET classification, just super selective ESD for just SM1 invasion is really difficult. Maybe that's why the histopathological criteria were different between US and Japan. In Japan, the pathologists diagnosed the intermucosal cancer. So the differential diagnosis between intermucosal or SM1 and SM2 is possible. But the differential diagnosis between M and SM1 is really challenging. That's my answer.
Good point. Mike, can you be back on the camera? I mean, I'm sorry, the Heidi or organizer. Yeah. So I have one question for you in relationship to that, the ratio of the SM1 cancer. Most of your study excluded suspected SM cancer to this, not doing the resection, going to surgery. Do you have data on those patients? How many were potentially salvaged by endoscopic treatment? Otherwise, SM1 cancer was included in the surgical case.
Thank you, Nori. Yutaka's excellent talk and some fantastic points about differentiating M from SM1, which I think also I agree is challenging. I think the ACE data that's presented, because it's from 2011 and it's only 500 cases, it's not really, of course, we've become more aggressive over time, and the cancer rate is, now, then it was 4%, but now it's around 8%. And but only about a third of those are low risk. We have actually run an analysis, but I don't have the figures in my head because I'm too confused with all the stuff that's going on. But so I don't know exactly the proportion of the various types of cancer, but we are working on publishing an updated paper looking at the trend in ACE over the long term, the last decade.
Okay.
Great. Well, thank you very much for an excellent talk.